Okay, let me see. Let me go back. Okay, you see this?
Yes.
Hello?
Yes. Okay.
Yes, okay.
Make it full screen. Yes. No, no, this is not yours.
No,
No, no. This is by. It's by
this is it.
Sophie's.
Maybe.
No, this is Enrico's slides.
Yes.
This is my slide.
Yeah, it's okay.
You mean
Enrico.
it
Just go to the full screen.
Okay. No, but this is.
how can you see this? It's small?
Okay. Okay.
Can you read this?
Yes. Okay. Now.
Okay, I'm not going to repeat all I said, but I want just to remind that the microcirculation is the place where the pressure is reduced because of the increase of resistance to flow. So it's responsible of total peripheral resistance. At the same time, of course, microcirculation is the part of the vascular district where the oxygen and metabolites are brought to the peripheral tissues. As I said, this microcirculation starts from vessels with a luminal diameter approximately below 350, 300 micrometers. And considering the hemodynamic effect of the microcirculation, its responsibility for the increase of peripheral resistance is due to functional mechanisms, so vasoconstriction, but also to structural alteration. And the two main structural alterations are, one, the increased wall-to-lumen ratio of small arteries, and the rarefaction of arterioles and capillaries. Rarefaction is very well demonstrated, and now it can be measured also using non-invasive techniques. And certainly it may contribute to an increase in resistance. But a large part of the increase of resistance is due to the structural alteration of small resistance arteries. The problem is that we have evaluated resistance arteries so far using some invasive, minimal invasive, but invasive technique that has limited very much the diffusion of the techniques in several laboratories. However, it has been a technique well standardized that has given us a lot of information, pathophysiological information, probably also clinical information. The small arteries is usually taken from subcutaneous fat through small biopsy, very small biopsy, and these small vessels can be dissected and mounted on a micromicrograph. There are two techniques that give the same results. And with this technique mounted on this micromicrograph, keeping the small artery in tension or pressure well settled, and in this experiment in vitro but ex vivo, because the small artery can respond to drugs and other maneuvers, it is possible to evaluate several parameters that are the wall thickness and the lumen diameters. Well, using this rather complex technique, however, we have had several important information. First of all, that very early during the disease, the small artery undergoes a remodeling that usually is a remodeling that induce an increase in the wall thickness and a reduction of the diameters according to a mechanism of rearrangement of the same material, of the smooth muscle cells around the lumen that leads to this increased wall to lumen ratio. But sometimes this is due to a growth of these smooth muscle cells, hypertrophy of these cells, and this is called hypertrophic remodeling. This is what happens in severe hypertension, also in diabetes, in obesity, in some secondary forms of hypertension, such as renovascular hypertension, primary aldosteronism, in acromegaly. Because of this remodeling of the small arteries, either eutrophic or hypertrophic, there are several important pathophysiological consequences. There is an amplification of any hypertensive stimulus. That means there is an increased vascular reactivity. For the same decrease of the diameter of the lumen of the vessel, there is an amplification of the resistance to flow. There is a reduction in organ flow reserve that may be particularly important in some crucial vascular beds, such as the coronary vascular bed. So at maximal vasodilatation, the flow reserve is reduced. And this is also a generalized phenomenon. This remodeling has been found in several vascular beds, including the cerebral vascular bed, including the coronary vascular bed. A third point is that this alteration has a very important prognostic significance. So we demonstrated this many years ago in patients at high risk, I have to say, and those with a wall to lumen, media to lumen ratio above the median had a less event-free survival than those with a media to lumen ratio below the median value. Here you can see the rate of cardiovascular events in those with greater wall to lumen ratio and in those with a lower media to lumen ratio. And this was also confirmed and demonstrated by other studies, by ourselves, in other laboratories, also in patients at lower risk. And the greater risk seems to be associated to so-called hypertrophic remodeling when there is real growth and hypertrophy. Well, on the other hand, this alteration, this structural alteration, can be reversed more or less by antihypertensive treatment. And we and others have observed that RAS blockers and calcium antagonists are more effective than diuretics and probably and possibly also of beta blockers, although only atenolol has been evaluated in this study. So most effective drugs are RAS blockers and calcium antagonists. Here you see the individual studies, and in square are those that brought the structural alteration to normal. If you start early the treatment, the remodeling can be completely normalized, and this obviously would be a very important goal. And again, you can see that hydrochlorothiazide in one study and atenolol in several studies were not able of regressing the structural alteration in small arteries. In diabetes, RAS blockers may reduce the structural alteration, the wall to lumen ratio, but was not able to normalize the structure. In this condition, as you might remember, there is hypertrophic remodeling, a greater alteration of the structure, and this is very difficult to regress and very difficult, if not impossible, to be brought to within normal limits. And what are the consequences of this regression of remodeling? We have data demonstrating that this permits better control of blood pressure, probably because of reduced vascular reactivity. For instance, we have observed that in patients with primary aldosteronism due to adenoma, after adrenalectomy, those with lower alteration in the structure of the small arteries were those who remained normotensive after treatment. So the amplification is not anymore working. We have also demonstration that with this regression there is an increase in organ flow reserve, in particularly of coronary reserve. And finally, there is a reduction of central blood pressure. Why is it? Because there is a crosstalk between the microcirculation and the macrocirculation. In fact, central blood pressure, as you know, is the result of the emerging of the forward pulse wave and of the reflected wave. The reflected wave comes from the periphery, from the reflection sites, from the small arteries probably, from the microcirculation. And if there is an increased stiffness of the large arteries, there is a damage of these reflection sites. If by treatment reflection sites are improved, if structural alteration regress, then there is a reflected wave. This means that the merging is during diastole. Otherwise, with alteration of these reflection sites, the merging is during systole. And this means that central blood pressure here in the aorta is higher. And this means more damage of the heart in this case, but also of the brain and also of the other target organs. So this crosstalk means that if we can reduce the wall-to-lumen ratio and improve rarefaction, we may reduce mean blood pressure, and this per se improve arterial stiffness, improve large artery remodeling, and is associated to reduction in central blood pressure or central pulse pressure. Less reflection site, less arterial stiffness. And this means less target organ damage and probably less cardiovascular events. However, as I said, the technique is invasive, although minimally invasive. What we need is something that is completely non-invasive. And the best vascular bed to assess microcirculation is the retinal vascular bed. We have to keep in mind also that cerebral arteries and retinal arteries share histological similarities and also some embryological common pathway. And we have the possibility now to evaluating precisely the wall and the lumen of the small retinal arteries, the arterioles. With this adaptive optics imaging, it is possible to have a very precise and reproducible measurement assessment. This is a technique that has used the way of reducing abnormalities in the astronomic optics instruments. So it is very precise, and with this technique we have observed that there is very good correlation between the wall-to-lumen ratio of retinal arterioles with this adaptive optics and the media-to-lumen ratio measured in this in vitro ex vivo technique in the subcutaneous more resistance arteries. Very close relationship. In addition, several studies have demonstrated that these retinal arterioles are significantly correlated with blood pressure, clinic, central, 24 hours, with pulse wave velocity, with history of cerebrovascular events, with urinary albumin excretion. And in a study, a combination of calcium antagonist and ACE inhibitors was found very effective in reducing wall-to-lumen ratio of retinal arterioles, more effective than the combination of the calcium antagonist with a diuretic. And this combination was also more the calcium antagonist plus ACE inhibitor more effective than calcium antagonist plus diuretic in reducing central pulse pressure and also in increasing capillary density. So in summary, some drugs are more effective, particularly RAS blockers and calcium channel blockers, in regressing vascular remodeling, while diuretics and atenolol do not improve vascular structure despite similar hemodynamic effect, by similar reduction of blood pressure. Now the point is, does regression of structural alteration of small resistance arteries possess a prognostic significance per se, independently of blood pressure reduction? This seems to be the case, but we have only one study in more than 100 patients with a very long follow-up, on average 10 years, but someone even more. In this study, it was demonstrated that for the same reduction of blood pressure, those in whom media to lumen ratio, wall to lumen ratio was below the median value had a greater event-free survival. The mortality of those with highest wall to lumen ratio was significantly more. But we have only this study, but this is the direction of cardiovascular protection. So, in summary, this remodeling in the small arteries is the most prevalent, the earliest form of target organ damage, even in mild essential hypertension. This may be observed also in secondary hypertension, obesity, diabetes mellitus, where the remodeling is more evident is in hypertrophic remodeling. It has clinical consequences, mainly reduction in organ flow reserve at maximal vasodilatation, and it has a very important prognostic significance. It is possible an improvement, even regression to normal after appropriate antihypertensive treatment, and also after weight reduction. And the extent of the improvement of microvascular structure during treatment may have prognostic significant as well. We need new technologies. These new technologies may help us in the near future to assess non-invasively the microvascular structural alteration, and therefore this may permit to better stratify the cardiovascular risk of our patients, and we may have also an optimization of treatment. Thank you very much for your attention.
Okay. Thank you very, very much. I think this will be the future, like the technology of measuring central aortic pressure, for example. This is another technique
Yes.
for measuring the microvascular resistance, and then how to measure, and then applying which drug for which. As we started now, ambulatory blood pressure, and we have maybe possibility of central aortic pressure measurement, but this could be a third technology rather than to just to give him blindly. What do you think in the future? Your a question? Yes. Yes. Tori.
Thank you for this presentation. This basic cardiology is very important for us. My question about the in hypertensive with left ventricular hypertrophy, regression of hypertrophy takes about 3 to 6 months after adequate control of blood pressure. Vascular regression of the vascular remodeling, it takes about 9 to 1 year. Correct me if, about this knowledge. The other points, is there rule of SGLT2 inhibitors for reverse vascular remodeling? But some papers mention this. Anti-diabetic SGLT2 inhibitors have a rule for regression of vascular remodeling in hypertensive patients?
Certainly, regression of vascular damage takes some time. For the small arteries, it takes, as you said, from 9 to 12 months. That's true. But full regression may be obtained only when treatment is started quite early. And the same is true for other organ damage, including an increase in left ventricular mass. Regression of left ventricular mass may be obtained in a long time. Yes, some studies have found a reduction in 6-9 months, but if we want a full regression within normal limits, it takes even longer. And I have to say that even when left ventricular mass is within normal limits after treatment, then the risk is not reduced to zero, or at least at the same risk of people who never had left ventricular hypertrophy. So the issue of regression of cardiovascular damage is still to be evaluated properly. I think that at level of small arteries, the regression, if started early, is a bit easier, because at beginning, the remodeling is just a rearrangement of the same material. There is no additional material. There is no consistent fibrosis, and therefore the regression may be easier. But this is just an opinion. And you are right that when the disease is advanced, the regression is very, very difficult. As far as the new drugs, anti-diabetes drugs are concerned, this has not been evaluated to my knowledge. As I said, it is very difficult to regress the vascular alteration in diabetes, because they are detected usually in an advanced stage, and the component of inflammation and fibrosis is very consistent. And as I said, there is hypertrophic remodeling in diabetes, and this is very difficult to regress.
Thank you.
Thank you very much, Dr. Rossi. There are no more questions, and it gives me a great pleasure to introduce the next presentation.